Okay, hi, good afternoon, everyone. So we'll start today's lecture. Today's lecture topic is on spinal anatomy and biomechanics. So we'll be covering this in two parts. Today's lecture topic is only on functional spinal anatomy. We have previously discussed a lot about spinal anatomy, particularly in the radiology lectures, but also in the craniovertebral junction lectures. So I'm hoping that we'll be able to recollect some of that. We're not going to repeat a lot of the concepts I've already learned in those sections previously. So if after this lecture you're confused, you can possibly go and visit those videos all over again. All right, so we'll start off with the section on functional spinal anatomy. So just a few basic ideas. There are 33 vertebrae, and when we are born, basically there's only one primary curvature, that is kyphosis, because evolutionary we have evolved from quadruped animals, and they only have one kyphotic curvature which exists. But because we have to stand and because we came to gravity, we developed these secondary curves, that is of cervical and lumbar lordosis. So the primary curve of kyphosis that is created by wedge-shaped vertebral bodies. But the secondary curves we develop because of gravity and because of us standing up, those are created by wedge-shaped intervertebral discs. And these develop after we're born. Now, to understand the basic concept of spinal alignment, so we have to understand that the primary curvature which exists is that of thoracic kyphosis. And then when we stand up, we develop the secondary curvatures of cervical and lumbar lordosis. And these two should basically compensate whatever is happening with thoracic kyphosis so that the spine overall is one straight structure. The basic idea is that your C7 plumb line, that is basically a line drawn from the mid portion of the C7 vertebra, should fall down and sit atop the L5S1 pivot point. The L5S1 pivot point lies at the dorsal end of the L5S1 intervertebral disc, so right over here. So if we were to drop a line from the C7 vertebra, this is, and it should be straight down. So it should come and lie just at this L5S1 posterior point. That's a pivot point. Now, if this line deviates in any direction from this point, you're going to have a mechanically unfavorable sagittal alignment. So we do not want that, because if the sagittal alignment becomes unfavorable, you're putting extra stress on both the axial musculature as well as on the bones and ligaments and joints, and this will result in early degeneration as well as pain. Now, the spinal alignment depends on the spine's relationship predominantly with the pelvis, because the main function of the spine is to transmit the load of the head and the thorax as well as the abdomen, ultimately down to the pelvis and then to the lower limbs. So the basic alignment has to happen between the lumbosacral spine and the pelvis. So there are ways that we can evaluate this. There are three parameters which describe this relationship. They are the pelvic incidence, the pelvic tilt, and the sacral slope. Now, this can be a little complicated to understand, but it's actually quite straightforward. So basically, we draw a line which connects the midpoint of the S1 upper end plate. So along the S1 end plate, we find the midpoint of that. So that is point A. Point B is at the anterior end of the end plate. So that is point B over here. So you draw a line connecting the two. It will just be along the upper end plate and line perpendicular to that. So this is the other line. And then one more line which connects point A with the center of the femoral height. The other line. The angle between the two, that is your pelvic incidence. And this is a fixed relationship which exists. It is between the perpendicular to the sacral end plate and the line connecting the sacral end plate to the femoral head. That is known as the pelvic incidence, and it defines the relationship between the sacrum and the pelvis. And this will not change. There are two other parameters, that is the pelvic tilt and the sacral slope. The pelvic tilt is basically the angle which exists between one line that we've already drawn, that is between the point A and the femoral head, and the angle between this line and the vertical reference line which exists. There is just a sagittal line, which is the vertical reference line. So between this and these two lines, that is the angle is known as the pelvic tilt. The sacral slope, on the other hand, is, as the name clearly tells you, it is just how far the sacrum is sloping. So between the horizontal reference line and the line that we drew between A and B, that is the sacral slope, right? So along the upper end plate of the sacrum, So this angle is a sacral slope. So we have two angles here. One is the pelvic tilt and one is the sacral slope. So these two together, if you're able to recollect geometry, would actually end up forming the pelvic incidence. So the pelvic incidence, as we know, is a fixed relationship between the sacrum and the pelvis. It will not change. But if you tilt the pelvis backwards or forwards, you can change the pelvic tilt and the sacral slope. So these can change with pelvic anteversion or retroversion. Now, patients, when they lose lumbar lordosis, this entire sagittal alignment will fall because now your L5S1 point is going to move a little bit more posteriorly, which means your C7 plumb line will form anteriorly to this point. Right. So to maintain sagittal balance, what patients will end up doing is they retrovert the pelvis a bit. Okay, so this will end up decreasing the sacral slope because this angle will then decrease once you retrovert the pelvis because the sacral slope will decrease. And then it will also increase the pelvic tilt because again, this angle will increase. Okay, so anyway, we are going to discuss more about spinal biomechanics in the next session. This is just a basic introduction as to how spinal alignment works. So just to remember, there is something called pelvic incidence, pelvic tilt, and sacral slope. Pelvic incidence is equal to pelvic tilt and sacral slope. Pelvic incidence cannot change, but pelvic tilt and sacral slope can, but depending on whether the pelvis moves anteriorly or posteriorly. The normal values of pelvic incidence lie between 55 degrees plus minus 10 degrees. And in a normal anatomy configuration, your amount of lumbar lordosis should be equal to the pelvic incidence within a range of about plus minus 10 degrees. And so that is all about spinal alignment. We'll come back to it in the next section. Coming to functional spinal anatomy. So this is a lot of these things have been discussed previously, but just go and learn about what is important for biomechanics as such. So the vertebra itself are the most important component of the spine. So they have to bear the entirety of the compressive forces and maintain the spinal strength. They have two important components, the body and the dorsal elements. The body is made up of both cortical bone as well as cancellous bone. The dorsal elements are predominantly made of cortical bone, right? So the body has to sustain most of the compressive force. The dorsal elements don't really provide any load-bearing elements to them. The body, since it has to sustain these compressive forces, it has this cortical bone. And the cortical lamellae are arranged vertically in the body. This is to resist the compressive forces. Now, the entire body could have been made up of cortical lamellae, but that would become very, very heavy. That is why cancellous bone is present inside the body. The only job of this cancellous bone is to make sure that the vertebral weight is quite low. Now, as we go down, more and more weight will be added to each successive vertebral body. That is why the lowest vertebral body is going to be larger than the uppermost vertebral body. As you go down, they become larger and larger. The dorsal elements, on the other hand, have completely different functions. Their predominant function is to protect the spinal cord. But apart from that, they also serve as a tension band. There's a lot of muscles and ligaments that attach to this entire dorsal elements, right? So there's actually a lot of tension which is held between these dorsal elements because of all the ligaments in between them, ligaments connecting them superficially, and all the muscles which are attaching to the spinal surfaces and the transverse surfaces. There's a lot of tension which is held between these dorsal elements, and they serve as a very good tension band. They also serve as a lever for muscles to act. In the dorsal elements, you have multiple different components. We know there's a pedicle. Then there's a transverse process, which is usually at the junction of the pedicle and the lamina. Also, the junction of the pedicle and the lamina, you will have the pars interarticularis, which will give rise to a superior and an inferior articular process. The laminae will then run posteriorly and join together and form the spinous process posteriorly. The same thing here. These are the pedicles. Depending on which level of the vertebra you're at, your pars and your transverse processes can vary. They can either be, the transverse process can be formed at the junction of the pedicle and the vertebra. That happens in cervical vertebrae. In all the others, thoracic and lumbar, the transverse processes arise at the junction of the pedicle and the lamina. Right? So, and then here after the pedicle, you have the lamina posteriorly, forming the spinous process. At the junction of the pedicle and the lamina, you have your facets and the transverse process. Now, One of the most important things we have to understand about instrumentation is that most of the screws these days, particularly dorsal spine and lumbar spine, are put through the pedicle. We're putting transpedicular screws. And the most important concept we have to understand to be able to put these transpedicular screws is what is the width of the pedicle. There are two pedicle widths. There's a transverse pedicle width and there's a sagittal pedicle width. Right, so this graph over here demonstrates the transverse pedicle width, and this graph over here demonstrates the sagittal pedicle width over here. Okay, and for instrumentation, it is only the transverse pedicle width which matters rather than the sagittal pedicle width. The transverse pedicle width is the lowest usually for the T4 to T6 vertebra. Okay, it is almost just 5. Okay, so above that and below that, the transverse pedicle width increases. So it decreases from the cervical to the mid-thoracic region. It will be lowest at the T4 to T6 vertebra. And then it will increase again below that and above that. The sagittal pedicle width, on the other hand, just increases up to the thoracolumbar level and then goes down. But this does not matter for instrumentation. So it's not really important. Another important thing to know is once you've defined the entry point, what should the direction of your screw be? So to understand that, we need to understand the transverse pedicle angle and the sagittal pedicle. The transverse pedicle angle is the angle of the pedicle in the axial plane from the reference line, which is perpendicular. Right. So this angle at the C3 level is quite high. As you can see, it's between 40 to 45 degrees. As you come to the thoracolumbar level, it falls down. So it successively comes down. At about T12, it's almost 0. And then again in the lumbar level, it starts increasing. So after T12 level, your screws will be almost straight inside. Okay. At T12, actually, you might have to point them out a little bit, even if it's negative. Okay. And then again in lumbar levels, you'll have to drag them medially. But for cervical levels, you can see at C3 and C4, it's quite medial. You'll have to drag them almost 45 degrees medially. In the thoracic level, somewhere between 10 to 15 degrees until you come down to T10 to T12 levels, which will be almost straight inside. And then when you go to lumbar levels, again, you'll have to drag them medially. Depending on each level, you can always refer to this graph to remember at which level what should be the angle. The same thing goes with the sagittal pedicle angle. So that is the angle between the horizontal reference line and the main axis of the pedicle. This, throughout the thoracic spine, is more or less the same. It is about 15 degrees. Okay. Below the thoracic spine and above the thoracic spine, both the cervical and the lumbar levels, it falls down. Right. So in the thoracic and thoracolumbar region, it's quite steep, but below and above that, it's almost 0. Right, so that's about the pedicles. Now, behind the pedicles, we have the facets and the interarticular processes. Now, facet anatomy is quite important, and it is also quite complicated. Throughout the different regions, it varies. Now, facet joints will have unique anatomy in every region, and the main support of the facet joint is the facet capsule. The thing is that the facet capsule remains relatively lax in cervical region. It does not contribute much to stability in the cervical region, and that is because the cervical region has to be the most mobile region on the spine. So that is why it is quite lax there. The main purpose of a facet joint is actually to restrict movement in a particular direction. But depending on the direction of the alignment of the joint, it will particularly resist one direction of movement while allowing other directions. So as you can see, this is the lumbar spine, and these are your lumbar facets. These are oriented sagittally over here. While these are coronal joints and coronal facets, and these are oriented coronally. We can probably see that better in our lateral view. But because they're oriented sagittally over here, these do not allow for rotation to happen. They don't allow for axial rotation. Right? So they're there to prevent rotation in this direction because they're sagittally oriented. While because the thoracic spine joints are oriented coronally, they're trying to prevent a translation. Apart from trying to restrict joint movement in a particular direction, they also share in load bearing. But it is important to remember that they share in load bearing in only extension. When the spine is flexed and it is bearing a load, facet joints are not under pressure. But when the spine is extended and it is bearing a load, then facet joints are under stress, and they do share in load bearing at that particular time. Almost 30% extra stress is applied on the facet joints in extension as compared to flexion. The thoracic facets that we have discussed, they lie in a coronal plane, right? This is the superior articular process, and this is the inferior articular process. The inferior articular process of the cranial vertebra. This is cranial. This is the inferior articular. Sorry, this is the superior articular process of the caudal vertebra, and this is the inferior articular process of the cranial vertebra, and that is forming one facet joint. Okay, the superior articular process and the thoracic spine is going to lie medially. It's going to be lying on the inside of the joint. Okay. Now, when we come to the lumbar spine, this is the superior articular process of the inferior vertebra, and this is the inferior articular process of the superior vertebra. As you can see over here, the superior articular process is going to lie laterally. So there's a difference here between the thoracic and the lumbar spine. When it comes to the L5-S1 level, the joint orientation changes again. The L5-S1 level, the joint orientation again becomes coronal. It should be sagittal in the lumbar spine, but L5-S1 becomes coronal because it is trying to prevent lysis. Okay, so just a brief description of the craniovertebral junction. We've already discussed this in detail. You're welcome to refer to the previous videos for that. The atlas and the axis form the craniovertebral junction. C0, C1 is basically the joint between the occipital cord beds and the atlas. It's primarily responsible for flexion extension of the head. It does not really allow for rotation. There are two important stabilizing muscles for this joint, the superior and the inferior oblique over here. As you can see, the superior oblique runs between the lateral mass of the C1 and the occiput, and the inferior oblique runs between the lateral mass of the C1 and the C2 spinous process. There are important ligaments of the CV junction, but limited to just C0, C1, you have the anterior and the posterior occipital membranes. At C1, C2, which is a joint between the atlas and the axis, that joint is responsible for the majority of the upper cervical rotation. The important muscles for C1, C2 are here the inferior rectus, the inferior oblique, and the rectus major over here. There are also multiple important ligaments, the alar, cruciform, and transverse ligaments. Again, we have discussed these previously, so we're not going to go through this all over again. Okay, now coming to the subaxial cervical spine, so that is from C3 to C7. The vertebral bodies, they gradually increase in size as you go down. The end plates of the vertebral bodies are concave superiorly and convex inferiorly. Okay. On the lateral aspects, they form the uncovertebral joints or joints of Luschka. Again, this is a concept we have discussed previously. These uncovertebral joints, they lie just anterior to the neural foramen over here, as you can see. So this is the uncovertebral joint over here, and just anterior to the neural foramen. Now, if there is any arthritic changes which develop in the joints, and that happens quite frequently in old age, they are going to create osteophytes that do impinge on the neural foramen posteriorly. Okay, now this neural foramen over here, we've all again discussed this previously, but just to revise, it is formed by the superior pedicle, the inferior pedicle, and anteriorly by part of the vertebral body. And one second. Right, so this is the superior pedicle. Yeah, this is the inferior pedicle, part of the vertebral body, and the intervertebral disc, and posteriorly by the facet joints, whereas the neural foramen view. Now, the neural foramen actually opens up and becomes larger when you flex the spine. If you extend the spine, on the other hand, the neural foramen becomes smaller. So one way that you can identify neuroforaminal stenosis is to do something called a spurning maneuver. That's basically you extend the spine, but also tilt it towards the side of the pathology. So if you're suspecting a right side foraminal stenosis, you have to both extend the spine and you should tilt it towards the right side. Okay, so that's a lateral flexion of the neck. Further add to the stenosis, you can even put some pressure on the head to compress the spine and further narrow the foraminal space. Apart from that, when it comes to cervical vertebrae, there are a few important aspects we've already discussed previously. The transverse process arises anteriorly as compared to other vertebrae. So it arises at the junction of the pedicle and the vertebral body, not at the junction of the pedicle and the lamina as it would over here, but at the junction of the pedicle and the vertebral body over here. The transverse process forms a bridge. There's an anterior and posterior tubercle where it has, and that forms a bridge through which you have a transverse foramina over here, and through which your vertebral artery will pass. So this is a very different thing about the cervical vertebrae. Apart from that, the cervical vertebrae have these facet joints, which are oriented partially coronally, but more or less they are flat. Okay. The other thing is that the cervical vertebrae, especially C3 to C6, will have biped spinal processes. The C7 spinous process is long, but it is not bifid. Okay. It has only a single process over there. The laminae of the cervical processes are quite narrow. They're not very tall, which means there's a lot of interlaminar space. It's very easy to get into this space when intersecting the muscles off. So if you're using monopolar in the cervical spine, you should be careful because there is a lot of space between the lamina. It is possible you can go inside and damage the dura or even the cervical spinal cord. The pedicles, when it comes to the cervical spine, are quite short and they arise from the midpoint of the vertebral body. As I can see over here, this pedicle, it's arising from, or here, this is arising from the midpoint of the vertebral body. There's some space above and space below. They have both a superior and an inferior notch. So that's a superior and an inferior vertebral notch in the pedicle. That gives rise to the neuroforamen. The transverse processes that we've already discussed, they arise from the junction of the vertebral body and the pedicle. And the C1 to C6 transverse processes will transmit the vertebral artery. In only 5% of cases will it also pass through C7. The facet joints are coronally oriented, but they are flat. They have a weak capsule, which, as we have discussed, because you require a lot of mobility in this region. Okay, so thoracic vertebra. So in an axial image, they have a heart shape. And as we know, all vertebra will increase as you go down from T1 to T12 in size. The thoracic kyphosis is a primary curve. It is caused by the wedge-shaped vertebra rather than the wedge-shaped intervertebral discs, which create the cervical and the lumbar lordosis. The first 4 thoracic vertebra and the last 4 thoracic vertebra, they have transitional features. So T1 to T4 will have some cervical features, and T9 to T12 will have some lumbar features. The cervical feature of T1 is that it has a superior vertebral notch, while the lumbar feature of T12 is that the facet joint is oriented sagittally rather than coronally. It also has an inferior articular process that is present only in lumbar spines and not in thoracic spines. The thoracic laminae are broad, as we can see over here, and they don't leave a lot of interlaminar space. So it is not as scary to dissect muscle off in the thoracic vertebral region. There's no interlaminar space. It's very unlikely that you'll enter the spinal cord or the dura. The pedicles, as we have discussed with thoracic vertebrae, are going to arise flush with the upper surface of the vertebral body, and they will not have a superior vertebral notch, but they'll have an inferior vertebral notch. The spinous processes, as we can see over here, this is a spinous process from the thoracic to the lumbar levels. The middle 4 spinous processes will basically point straight down. While if you go above that and below that, they'll have a little bit more oblique direction. And then at the end, they'll be a little bit more horizontal. So at T1 to T2 and T11 to T12, they're more horizontal. At T3, T4 and T9 to T10, they're more oblique. And T5 to T8, they are vertically down and overlap with each other. The transverse processes basically point laterally and dorsally. So you can see point laterally, and they also point posteriorly. Okay, and they connect with the ribs, except at T11 and T12. That is where the ribs do not connect with the transverse processes. So the transverse processes have costal facets for rib articulation, but not at T11 and T12. Now, the thoracic spine, because it is so rigidly fixed by the ribs also, has a maximum amount of stiffness. And regions where this joins up with the mobile regions of cervical and lumbar spine are known as junctional regions. So the C7, T1, and T12, L1. These are sites of transition from a rigid to a mobile spinal region. And this is also usually where you get common sites of pathology. Now, these are the different thoracic vertebrae, as we've discussed. There's a small superior vertebral notch in T1, which should not exist. Okay, you can see the body over here, and as we go down, the body becomes bigger and bigger. Another thing to notice is as you go down, there is no superior vertebral notch. But as we go further down, the costal facets, which are initially lying on the body, they move more and more posteriorly to end up lying on the pedicle. So at the T12 level, the entire costal facet lies on the pedicle. Now at T1, the T1 body has the entire facet to connect with the first rib. From T1 up till T10 level, there are only demifacets. That is for the second rib, it has to connect with both the second vertebral body over here, as well as the first vertebral body. So there'll be a demifacet on the second vertebral body, and there'll be a demifacet on the first vertebral body. So the rib will come and connect to both. They connect to its like numbered vertebra, that is T2, and the vertebra above. And that will continue till T10. But for T11 and T12, they again have their own complete facets. So 11th, 10th, 12th rib will not connect with other vertebra, but except just the vertebra that is a like numbered vertebra. So coming to the rib articulations, as we discussed, the first rib articulates only with T1 via a complete facet. Ribs 2 to 9 will articulate with demifacets, so they'll connect with two vertebrae as we discussed. For T10 to T12, they'll again connect with a single complete facet. And the articulation moves dorsally. It moves from the body to the pedicle. So as we see, it was on the body, and then as we move down, the articulation comes to lie on the pedicle. For the 11th and 12th rib, these do not connect with the transverse processes. For the other ribs, they also have a process they have a facet on the transverse processes, which also forms a costotransverse junction. Okay, now coming to the lumbar vertebrae. The lumbar vertebrae are kidney-shaped in an axial image. The transverse width is more than the AP diameter of the lumbar vertebrae. As we have discussed, the lumbar lordosis is created by a secondary curve, and it is created by the wedge-shaped intervertebral discs rather than the shape of the vertebral bodies. But there is some regional variation which happens. Now, the L1, L2 bodies are going to be taller dorsally here than they are ventrally. L4, L5 bodies, on the other hand, are going to be taller ventrally than they are dorsally. So whenever there is lumbar flexion at the level of L4, L5, there is going to be more space posteriorly. And that is why there's a greater dorsal disc bulge. On the other hand, there is not so much space at L1, L2 when you are flexing. So there is not so much of a disc bulge. This is one of the reasons why L4, L5 disc pathologies are a lot more common. Okay. Now, behind the vertebral bodies, we have the neural foramina over here. The neural foramen becomes larger in flexion, and it decreases in area in extension. So that is what happens when you have neural foraminal stenosis. If you ask a patient to extend, they will have further worsening of the pain because the foraminal area will decrease in extension. The facet joints of the lumbar spine are oriented sagittally, as we have already discussed. The superior articular process is going to lie laterally. There's the inferior articular process lying medially. This is basically to prevent rotation. The L5S1 facet, on the other hand, it's oriented coronally, as you can see over here. This is predominantly to prevent L5S1 dehiscence. At the junction of the superior articular process and the transverse process, you have the tubercle over here, which is known as a mammillary process. This mammillary process is important because this is used to guide your transpedicular screws. The transverse processes on the lumbar spine are more obvious in the thoracic spine, and they point directly laterally, not dorsolaterally. So these are our lumbar spines. As you can make out, they are quite different looking from the cervical spines and the thoracic spines we've seen so far. Okay, so there's a much bigger body over here. The pedicle also will have a superior and an inferior notch. Okay. The pars interarticulus and the facets again arise at the junction of the pedicle and the lamina. And the facet joints are quite prominent and quite obvious. In the thoracic spine, they're not as obvious, but in the lumbar spine, they're a lot more obvious. Okay, well, now coming to the intervertebral discs. The intervertebral discs are basically made of three components. They have a central nucleus pulposus and a peripheral annulus fibrosus. But it also includes the cartilaginous end plates on both the superior and the inferior aspect of the disc. Intervertebral disc has two main functions. One is that it is important for mobility also. It forms part of a joint complex that will contribute to the spine's mobility. Other thing is that it does absorb the compressive loads. The main responsibility of absorbing compressive loads falls on the intervertebral discs. And it is able to do this because it has a property known as viscoelasticity. It is both a viscous and elastic material. And this property is conferred entirely by the nucleus pulposus. Now, what does it mean to be both viscous and elastic? Now, if a compressive load that is applied slowly, then the disc will deform to a great degree. Excuse me. But if a load is applied rapidly, then a much lesser amount of deformation will occur. Now, there are 23 intervertebral discs starting from C2, C3 and going all the way up to L5S1. And they form approximately 25% of the vertebral height. The discs become bigger and bigger in cross-sectional area as you go from top to bottom. But they're the thickest in the lumbar spine and the thinnest in the thoracic spine. And the nucleus pulposus in the thoracic spine is centrally located. While in the lumbar spine, predominantly because of the lumbar lordosis and because the lumbar spine is to tolerate the most amount of compressive load, the nucleus pulposus is going to be located more posteriorly or more dorsally. Here is the nucleus pulposus within the intervertebral disc, just surrounded peripherally by the annulus fibrosus. Now, the nucleus pulposus has been derived from the notochord, which is made of endoderm. So it is the only endodermal remnant within the spine. Excuse me. It is soft, deformable, and gelatinous. It is made up of 70 to 90% of water. Now, how is it able to hold all this water? It is able to hold all this water because it has these mucopolysaccharides known as aggregans. The aggregans have negatively charged side chains, which are able to retain all this water. And that is what is responsible for the viscoelasticity of the nucleus pulposus. It also contains type 2 collagen and elastin. So these are all together important for the load-bearing properties, but the most important characteristic there would be the aggregans, which is able to hold all this water. The nucleus pulposus is then surrounded by annulus fibrosus. And these are made up of basically concentric laminated bands of collagenous fibers. As you can see over here, these are all the bands. There's one band here, one band here, one band here, one band here. Now, all these bands have fibers which are oriented in different directions. And for each band, the orientation is basically at a 90-degree angle to the previous band. So each annulus has about 15 to 20 of such lamellae, and each band is oriented 90 degrees to the adjacent band and about 30 degrees to the disc plane. The inner fibers, so the fibers towards the nucleus pulposus, they are the inner fibers, they will be attached superiorly and inferiorly to the cartilaginous end plates, while the fibers at the edge, the outer fibers, is known as Sharpie fibers. And the Sharpie fibers, on the other hand, are attached to the cortical bone of the vertebral body. So it keeps the disc attached to the vertebral body through Sharpie fibers. Now, the inner annulus fibrosus is a little bit more like the nucleus pulposus in that it has more type 2 collagen and it is softer. It is more nucleus pulposus-like. The outer annulus fibrosus is stronger. It is mostly type 1 collagen. The third component of the intervertebral disc is the cartilaginous end plate. And this basically prevents disc material from getting out and going into the vertebral bodies. It also serves to provide nutrients and fluids to the disc. So it has two basic purposes. Now, each cartilaginous end plate is made up of a thin layer of bone and a thin layer of hyaline cartilage. With aging and degeneration, it can develop some areas of weakness, and through that, your disc material can herniate, and these are called Schwann nodes. Sometimes you can see the small amount of disc material which has gone into the vertebral body, and that is because the cartilaginous end plate has broken down in that region. At a very young age, the cartilaginous end plate has perforations which allow the passage of vascular channels to the disc. And these do supply the disc up to basically the second decade of life, beyond which these channels will regress and the disc does not have any vascular supply. So, as in infancy, actually, the disc gets supplied by branches of the ASA and the vascular channels that we discussed going through the cartilaginous end plates. But everything will disappear by the second decade of life, following which the disc is only going to be supplied by diffusion coming in from the blood vessels at the periphery of the annulus or through the cartilaginous end plate. The intervertebral disc, it's supplied by two types of innervation. One is a sinovertebral nerve, and another is from the autonomic nervous system. The sinovertebral nerve is basically a recurrent meningeal nerve. From the ventral ramus of a spinal nerve, you get a recurrent branch which goes back to the intervertebral foramen and forms a sinovertebral nerve. This basically is supplying the vertebral body, but it also is able to supply the intervertebral disc, but only the posterior and the posterior lateral aspects of the annulus fibrosus. The anterior aspect and the lateral aspect of the annulus fibrosus, on the other hand, is supplied by the sympathetic trunk, which is lying anteriorly. So directly from the sympathetic trunk, you get multiple gray rami communicantes, which will supply the lateral and the ventral portions of the annulus fibrosus. Now, the innervation of the disc is limited only to the outer parts of the annulus and not to the central part of the disc. The disc also has, apart from aggregans, it also has collagen and other extracellular matrix components, and these are under constant anabolic cycles. The aggregans will create a hydrophilic environment, and we know that is what provides viscoelasticity. With aging, these will get broken down, and the proteoglycans get replaced. So from aggregans, they become non-aggregated proteoglycans, which have less water retention. So as we age, the discs are able to retain lesser and lesser water, and that is what leads to stresses developing on the end plates and on the facets. Also, within a normal disc, there are mechanisms which help to keep a disc healthy. There is one of the disc metabolism. There's anabolic factors like IGF, insulin growth factor, TGF-beta, and bone morphogenetic protein, which help to proliferate cells and deposit extracellular matrix. There are also matrix metalloproteinases which try to break all this down. So in disease states, these go up and they further try to decrease disc metabolism. The tissue inhibitors of metalloproteinases try to inhibit this. So we have a cycle just trying to make sure that the discs are healthy. But mechanical forces can affect this metabolic balance. So if you have normal, moderate compressive forces acting on the disc, it will actually help make the disc stronger by stimulating the formation of extracellular matrix. But if you have persistent heavy loads on the disc, this will inhibit matrix synthesis and stimulate activity, which will lead to further breakdown of the extracellular matrix. As we've discussed, disc nutrition basically happens by diffusion. It will also happen by convection transport. The cartilaginous end plates basically form a selectively permeable membrane, and this will provide some pathway for diffusion to occur. But with age, this will calcify, and over time, the nutrition to the disc will come down. Also, normal mechanical loading cycles, just flexion and extension, will also mobilize 22% of the total volume of the intervertebral disc. So when the disc is under compression, water moves out of the disc, and when it is released, the water can move back into the disc. So that also has metabolic transfer. But overall, an intervertebral disc is relatively hypoxic, and that is why it is so difficult to repair a disc. Also, if you get disc infection, it is very difficult for it to get eradicated. Smoking can further decrease nutrient supply to discs, so it is important to advise patients not to smoke when they already had disc problems. So how a disc works is basically if you have, this is the vertebral bodies, and we have the disc. This will be the annulus fibrosus, and here in the center will be the nucleus pulposus. So whenever you have compressive forces, the compressive force will predominantly act only on the nucleus pulposus. The nucleus pulposus is going to deform under these compressive forces and redistribute these radially to the annulus fibrosus by deforming. Because of which, the compressive forces don't directly act on the annulus fibrosus, because the annulus fibrosus would not be able to tolerate these direct compressive forces. And it is able to tolerate these radial forces coming from the nucleus pulposus instead. These act on the annulus fibrosus, and because it is very good at tolerating shear forces and torsional forces, it is able to take care of these radial forces coming out from nucleus pulposus instead. As you age, the nucleus pulposus becomes stiffer. It is not able to deform under the compressive forces, which means that the compressive forces now travel to the annulus fibrosus. And that annulus fibrosus is not able to normally tolerate these forces, because of which it breaks down, leading to annular tears. This also can lead to further stress on the cartilaginous end plates, which can also break down and lead to fractures of the vertebral body as well. Okay. Now, coming to the spinal ligaments, there are 7 major spinal ligaments. We've already discussed a lot of these before. Just to remind us, from anterior to posterior, you have the anterior longitudinal ligament. On the anterior surface of vertebral bodies, you have the posterior longitudinal ligament on the posterior surface. You have the intertransverse ligament between the transverse processes. You have the ligamentum flavum running on the inner surface of the laminae. You have the facet capsular ligament. You have the interspinous ligament, and then you have the supraspinous ligament. Now, the effectiveness of any ligament will depend not only on its strength and its morphology, but also on the length of its movement arm. Now, when it comes to, for example, flexion and extension, if you take this as a center of rotation, these are the moment arms of all the different ligaments. Okay. So as you can see, the only ligament which deals with extension or prevents hyperextension would be ALL. In extension, none of the other ligaments will be able to act because they're on the same side of the axis of rotation. For flexion, on the other hand, the strongest ligament is the ligament which is furthest away from the axis of rotation, or which is the longest moment arm. So for flexion, the strongest ligament is actually the supraspinous ligament or the interspinous ligament even. But the supraspinous ligament would be better because it is further back. PLL, on the other hand, for extension, for flexion, does not have a very good moment arm, and it does not do a very good job of preventing hyperflexion. Okay, so the anterior longitudinal ligament, it is a ligament extending from the top to the bottom. It extends from the basion to the sacrum. It covers a significant portion of the anterior surface of the vertebral bodies and discs. And also, it is important to keep the discs intact. It attaches to the annulus fibrosus and helps provide support to the discs. As we've discussed, it is the only ligament lying anterior to the axis of rotation. So it is the only ligament which prevents hyperextension. It has 3 layers. Okay, so ALL and PLL both have 3 layers. There's an outermost layer. Okay, so if this is the vertebral body. Okay, so we can draw multiple vertebral bodies. 1, 2, 3, 4, and 5. So there'll be 3 layers. The innermost layer will basically attach like 2 intervertebral discs. The middle layer, which will then connect at least 3 vertebral bodies and discs. And then there's an outermost layer connecting at least 4 to 5 different levels. Okay. Same thing with PLL. It also has similar 3 layers. Now, PLL is slightly different than ALL. PLL starts a little bit lower down. It starts at T2 as a tectorial membrane and extends all the way to the sacrum. The PLL basically is narrow at the level of the vertebral bodies and flares at the level of discs. So if you're looking from posteriorly, this is the vertebral bodies. We're looking from behind the vertebral bodies. Okay, so this anywhere will be your PLL. Okay, so it'll be narrow at the level of the vertebral bodies and then it'll flare out at the level of the disc. So it is able to nicely cover the disc material and provide quite good support at the disc level. Okay. Now, it is interwoven to the annulus fibrosus and loosely attached to the vertebral bodies because it's primarily trying to prevent the disc material from extruding into the spinal canal. It does prevent hyperflexion to a certain degree, but not a lot. It has 3 layers. It only has a modest contribution to spinal stability, but as we discussed, it helps disc herniations to stay away from the central portion of the spinal canal. It directs a disc herniation laterally on the other. The ligament of flavum is a very important surgical ligament. It is a discontinuous ligament, okay, and laterally it goes and joins up with both sides facet joint capsules. Now, it can be complicated to remember exactly how it is attached. So, if we look at imagine this is the lamina above and this is the lamina below. Each lamina has a ventral surface and a dorsal surface. The dorsal surface is where the spinous process is present. Okay. So the ligamentum flavum originates here at the ventral surface of the cranial ligament, and then it attaches at the dorsal tip of the caudal vertebra. The cranial vertebra, this is the lamina over here, the ventral surface, the inner surface, comes down, attaches to the dorsal lip of the superior surface of the lamina. Okay. Now, the ligamentum flavum is quite elastic, and it basically what it does is that whenever you have flexion, it will stretch during flexion and does not prevent motion as such. And then when you're returning back to neutral during extension, it will become taut. So it will become tight during that time and it will not buckle inside. That is because it is elastic. Now, with aging, this elastin gets replaced by collagen and it will lose elasticity. So what happens with time is when you're in the neutral position or in the extended position, the ligamentum flavum tends to buckle. And this buckling is what can compress the spinal cord in degenerated spines. The ligamentum flavum has two layers, and this is important to remember when we're doing surgery. Between these two layers, you can actually create a space. The outer layer is also discontinuous in the midline. This creates an easy midline cleavage plane for dissection. So you can go into the interlaminar space, and if you want to dissect out the ligamentum flavum, just go look for the midline and try to create a space in there. Even if the ligamentum flavum is hypertrophied, this midline cleavage plane will still exist. The other important ligaments are the interspinous and supraspinous ligaments. As we saw, they have long moment arms, and they provide a very good resistance to hyperflexion. Okay. Now coming to spinal musculature is like very unnecessarily complicated topic, so we're not really going to discuss it in detail. An important thing to remember is that spinal musculature is very, very important for spinal balance. Now, the entirety of the body weight more or less lies anterior to the spine. And so the spine obviously should have a natural inclination to fall forwards and collapse into flexion. That is why back musculature is so important, because it balances the forces on the vertebral column. Now, there are extrinsic and intrinsic back muscles. The extrinsic back muscles are the latissimus dorsi, the trapezius, the rhomboids, and the serratus posterior. They predominantly act to stabilize the the spine, but they're not really back extensors as such. The back extensors are basically our intrinsic muscles. Right? So there are multiple layers of the intrinsic muscles. There is the superficial layer, which has a scaenius capitis over here. This is a scaenius capitis. And then it has a scaenius cervicis. There's an intermediate layer which contains all the erectus spinae. There are three columns of erectus spinae, the ilia costalis, which is lateral, the longissimus, and then the mediama, which is spinalis. The basic concept is just that they provide back extension. There's a deeper layer to the erectus spinae muscle. That is the semispinalis, multifidus, and rotatoris. The semispinalis has three components: the capitis, cervicis, and thoracis. And all of these basically serve to provide neck extension and back extension. Okay. Now coming to the nerve roots. In the cervical, very important thing to remember, and I think all of us know this, that with growth, the spinal cord is going to turn out to be much shorter than the spinal canal. Right? So that is why the cervical nerve roots will be coursing straight horizontally, while below that, from the thoracic point onwards, especially in the lumbar and sacral region, they have to course a significant amount inferiorly before they can exit the neural foramen. And another thing to remember is that the cervical nerve roots are going to be exiting above the same numbered pedicle, while below C8 level, the nerve roots will be exiting below the same numbered pedicle. In the cervical nerve spine, the roots will course horizontally and they will exit the foramen above the like-humbered pedicle. So C6 nerve root is exiting above the C6 pedicle in the C5, C6 foramen. Can be easily confused here, but it's important to remember this. Below the cervical spine, the nerve root will course below the pedicle. So your D3 nerve root is going to be exiting below the D3 pedicle in the D3 and D4 foramen. In the lumbar spine, they will angulate quite obliquely. And when they're trying to pass below the pedicle here, they will end up coming in contact with the intervertebral disc. Right? So what happens here is in a lumbar discectomy, the disc fragment usually, so this image is not the best to describe this because this probably is at a dorsal level. So if the nerve root was coming from a little bit higher up, for example, like this, and exiting here, disc over here would compress this traversing root. At the level of the lumbar disc, usually, if you're doing a lumbar discectomy, the disc fragment is actually located at the shoulder of the disc, which is above the disc. And you can find the disc fragment by retracting the nerve towards the cord. On the other hand, in a cervical disc, because the nerve comes out basically horizontally, the disc will be located below the nerve or in the axilla of the nerve. And that is why the nerve needs to be retracted upwards and not towards the spinal cord. If it's retracted towards the spinal cord, you're not going to find the disc. In cervical discectomies, you have to retract the nerve root away from the spinal cord. And in lumbar discectomies, you have to do the opposite and retract it towards the spinal cord. Now, a very important concept and quite simple to understand is that of the traversing and the exiting. Basically, there's something known as a lateral recess, which exists particularly in the lumbar levels. We do not have a lateral recess in the cervical levels. It does not exist. There's no space there for that. Now, what happens is that between the dura and the medial border of the pedicle, you have this small space, or the lateral recess. And close to the medial border, the nerve root will come and lie when it is trying to exit below. Okay, so the traversing root lies in the lateral recess over here. Okay, so in lumbar disc herniations, your herniations end up happening most commonly paracentrally in this region. This is a paracentral disc herniation. Now, disc herniation can also happen far laterally over here as well. A far lateral disc herniation will affect the nerve root that is exiting at that level. Okay, so that will affect the exiting nerve root. If this is the L4 pedicle and this would be the L5 pedicle, the exiting nerve root at this level will be L4. So this is the L4 nerve root. The far lateral disc will affect the L4 nerve root. But on the other hand, if you have a disc herniation happening here, the nerve root which is going to be coming immediately medial to the medial side of the pedicle is going to be the nerve root which is going to exit inferiorly. That is the L5 nerve root. So same level of disc herniation, L4, L5, but if it's far lateral, it affects the exiting nerve root. If it's paracentral, it affects the traversing nerve root. The traversing nerve root is the lower nerve root. So at an L4, L5 disc herniation, most common afferent nerve root will be L5 because the most common type of disc herniation is paracentral. Far lateral disc herniation are quite rare. Okay. Another thing which can happen and can cause significant confusion with nerve roots are something known as conjoined nerve roots. Now, these conjoined nerve roots can happen intradurally or extradurally or extraforaminally. Now, intradural connections are a lot more common than extradural connections. They're known as conjoined nerve roots, where the nerve roots join together. Now, what can happen is that they join together and then they exit from the same foramen. So that is two nerve roots exiting from the same foramen. So here, again, you can have a disc happening at a higher or lower level, and you can have a radiculopathy happening at a different level, and you can get very easily confused. Another thing which can happen is that the nerve roots can join together or arise at the same level and then divide and run out. So this can be difficult to identify. But one clue to identify is look at sagittal T2 weighted images. Now, sagittal T2 weighted images, This is how the neural foramen usually looks. And this is the superior border, this is the inferior border, this is the anterior border, this is the posterior border. The nerve root should be lying as close as possible to the pedicle or the superior border. Now, whenever you have a conjoined root, it ends up pulling the nerve root down. So your nerve root instead now may lie more inferiorly or in the middle rather than lying superiorly. So this is one indication that you have a conjoined nerve root. Right. So that is all for today's lecture. We'll try to answer a few questions. You can leave the answers in the chat box. So can anybody identify the hidden structure in this image of the intervertebral disc? Is it the anterior longitudinal ligament? Is it Sharpie fibers? Is it the posterior longitudinal ligament? Is it cartilaginous end plate? Okay, these are part of the annulus fibrosis, which are attaching to the edge of the bony vertebra. These are the Sharpie fibers, which are the outermost fibers of the annulus fibrosis, which attach to the bony vertebra margin. Second, which of the following is true about spinal biomechanics? Spinal musculature does not have a significant contribution to spinal biomechanics. Pelvic incidence is a modifiable factor. Facet joints bear compressive loads and extension, but not in flexion. The cervical rotation primarily occurs at C0, C1 junction. Yes, so facet joints bear compressive loads in extension, but they do not do so in flexion. Okay, this is quite straightforward and simple. Identify this vertebra. Is it C5, T1, T12, or L4? Right, so easiest clue here is a facet over here. It's a complete facet located on the pedicle completely. So this is the T12 vertebra. And the last question, which of the following ligaments best prevents hyperflexion? ALL, ligamentum flavum, or supraspinatus ligament? Right, so the ligament with the longest movement arm is the supraspinous ligament. So it is the ligament which does its best to prevent hyperflexion. Okay, so that is all for today's lecture. If you have any doubts, you can leave them in the chat box.